in the bottom of your screen,
Uh-huh.
but I think
Okay.
I'll turn it off. Hi, everyone. Welcome to our multi-heart lecture series. It's a great pleasure to have today Dr. Gianluca Iacobellis, who will be speaking about. Start again. Hi, everyone. Welcome to our multi-heart lecture series. It's a great pleasure to have today Dr. Gianluca Iacobellis, who will be speaking about epicardial adipose tissue from cell to clinic. Dr. Iacobellis is a professor of medicine and director of the University of Miami Hospital Diabetes Service. So Dr. Iacobellis is a native of Rome in Italy and received his MD with cum laude in 1994 from the University of Rome La Sapienza. He was a research fellow in the Center of Metabolism and Endocrinology at the Karolinska Institute in Sweden in 1999. Then he became a specialist in endocrinology in the 2000 and obtained his PhD in endocrinology, metabolism, and cardiovascular disorders in 2004. In 2006, Dr. Iacobellis was appointed as an associate professor of endocrinology at the Department of Medicine at McMaster University in Canada. And then in 2010, he was invited from the University of Miami in Florida to join as an associate professor of clinical medicine in the division of endocrinology, and then promoted to professor of medicine and director of the hospital diabetes service. Dr. Iacobellis has pioneered the research in the epicardial fat and discovered the echocardiographic epicardial fat quantification as a new marker of visceral fat and as a therapeutic target. He's considered the worldwide leading expert in epicardial fat as a new cardiometabolic risk factor. As of today, Dr. Iacobellis has authored 155 scientific articles, over 10 textbooks with a current H-index of 61 and more than 16,000 citations. He has published in top-ranked journals such as Nature Endocrinology, Nature Cardiology, Trends in Endocrinology and Metabolism, European Heart Journal, JAMA, etc. He's also a co-principal investigator of two NIH-funded R01 clinical trials on the role of epicardial fat in coronary artery disease and atrial fibrillation. It's a great honor to have you here. We've been reading your papers for a long time now, so thank you very much for taking the time, and we're excited for your lecture.
Thank you very much, Leandro, for this kind introduction. It's a pleasure to be here with us. So, first of all, what is epicardial adipose tissue? That's the main. I was just chatting with Leandro before to start this presentation and how everything started. And I was a pure clinical observation when I was a young fellow, young resident, looking at the echocardiogram and looking at these basically neglected echo-free space on the parasternal long axis view. And I was just looking at the patient and saw that there was a strong correlation between the abdominal fat, the belly of this patient, and this echo-free space. So then I started analyzing these previously almost obscure fat depot. So the epicardial adipose tissue is the true visceral fat depot of the heart, because it's located between the myocardium and the visceral layer of the pericardium. And this is not just a trivial point, because it has to be strongly differentiated from the pericardial adipose tissue, and because the pericardial fat is within the visceral layer of the pericardium and the parietal layer of the pericardium. So it's more external, and so it's not in the direct contiguity with the myocardium as epicardial adipose tissue is. And this is, again, makes a big difference also, not just a matter of terminology, but also in terms of anatomy, pathophysiology, and clinical implication. Microscopically, epicardial adipose tissue is a unique fat depot, because it's in direct proximity to the myocardium. In this slide on your left, you see the lipid buckle of the epicardial fat, and you see the underlying myocardium, and you can appreciate that there is no muscle fascia that separates the two tissues. So the epicardial fat is anatomically proximal to the underlying myocardium, and this is unique. No other visceral fat depot has this feature. This makes a big difference because in the two tissues, so the myocardium and the epicardial fat, cross-talk, so they communicate because there is no anatomical separation between them. So epicardial adipose tissue has physiological and pathological functions. So this is very interesting. And so in this cartoon, you can nicely see the evolution of the epicardial adipose tissue, the changes with aging and pathological conditions. So at the beginning, in our early years of life, the epicardial adipose tissue it's extremely cardioprotective. So because it has a brown adipose tissue features. And this is very interesting, very unique as well. So when we were born and in the first years of our life, we have a lot of these epicardial fat with brown fat like characteristics that serve as fuel for the myocardium as a thermogenic and protective fat depot. When we move, we advance in our life from childhood to the adulthood, these unfortunately these brown fat-like characteristics tends to decline, and with the old age, the thermogenic function disappear almost, and in the profibrotic and pro-apoptotic changes are more prevalent with the older age. And under pathological conditions, so the epicardial adipose tissue tends to be larger and with more pro-inflammatory macrophages and more pro-inflammatory profibrotic factors, and again with apoptotic changes within the adipocytes. One of the other unique features of the epicardial adipose tissue is intrinsic inflammation. So on your left, you have a comparison between epicardial fat and subcutaneous fat from the same patient. And you can really appreciate the dense inflammatory infiltrates within the epicardial fat as compared to the subcutaneous fat. And this dense inflammatory infiltrate is mainly made by T cells, mast cells, and one macrophages, so pro-inflammatory macrophages. So even microscopically, you can appreciate the dense inflammation that these adipose tissue. This inflammation is also clinically. You can approach clinically, and during the COVID we did several studies, and we measure the epicardial fat inflammation with the CT scan and measuring the HU, so which is a marker of the density of the epicardial fat, and also marker of inflammation. And we found this very interesting, and we published that the more severe was the COVID-19, the more inflamed was the epicardial adipose tissue as per CT HU values. So it's not just anatomically or biochemical changes, but also there is a stronger clinical translation of these highly inflammation adipose tissue. Then we look at the genetic features of the epicardial adipose tissue, and we did several studies. One of the first was a microarray analysis of the epicardial fat that we collected during cardiac surgery, and we also collected the subcutaneous fat from the substernal incision, and we compare the microarray profile of the epicardial versus subcutaneous fat. And we found unique features, so that the epicardial fat has a highly inflammatory transcriptome. So we know now that it has inflammation within the cells. We know it has a clinical translation, but also has a strong inflammatory transcriptome. But not only, so the epicardial fat was highly enriched with genes involved in the endothelial function, coagulation, immune signaling, and there is a strong interaction between immune signaling and inflammation, but also interesting with the genes involved in potassium transport, for example, and apoptosis. Again, apoptosis seems to be very important, particularly in advanced chronic conditions like advanced CAD or also with older age. Then we more specifically look at whether the transcriptome of the epicardial adipose tissue was different in diabetes versus non-diabetes. And interestingly, we found that almost 600 genes of the epicardial fat were unique in people with diabetes as compared to those without diabetes. And these genes were mostly encoding for transcriptional factors like FOSL1, AMP1, but also with well-known inflammatory cytokines like interleukin 6 and TNF-alpha. So the diabetic epicardial fat transcriptome is also unique. Then we were not satisfied yet, and we wanted to see whether there was a regional differences in epicardial fat in terms of correlation with disease and clinical implication, because we found that the heart has epicardial adipose tissue, of course, but it's not equally distributed through the heart, and there are different regions, and they have different characteristics. So you can find epicardial adipose tissue surrounding the left atrium, and you can find epicardial fat infiltrating the coronary arteries, and they are very different. It's something that you may not expect. So they are different in terms of transcriptome. So the epicardial fat surrounding the left atrium is enriched with genes involved in encoding for fibrosis, inflammation, and autonomic control. Whereas the epicardial fat infiltrating the coronary artery is more enriched with the genes involved in inflammation, glucotoxicity, and lipotoxicity. So the transcriptome and the secretome of the epicardial fat is different depending on the location. And this is extremely fascinating, a new finding, because we will see later that we can actually target depending on the conditions, the different fat depots, different regional epicardial fat. So starting with the coronary artery disease, so epicardial adipose tissue has a strong atherogenic effects, and it's a very complex mechanism that has different pathways, and clearly inflammation is involved. You can see on the left of this cartoon that the epicardial adipose tissue has an increase of transcriptional factor like GNAK and AFA and FKB and toll receptor signaling that activates an inflammatory response, particularly interleukin 6, TNF-alpha, and this leads to an increased inflammation. But again, given the absence of barrier between the fat and the myocardium and the coronary arteries, the inflammatory secretome goes directly into the coronary artery lumen. But it's not the only mechanism. So you also have an increased lipid infiltration, which is also very important. So epicardial fat is enriched with genes encoding and regulating FAP, so free fatty acid oxidation, particularly FABP4 and SPLA2. And there is an increased FAP influx from the fat into the atherosclerotic plaque. And this builds up the lipid component of the atherosclerotic plaque. And also there is, as we learned before about diabetes, a role of hyperglycemia. So epicardial fat in condition of a hyperglycemia, it's highly enriched in age-rage signaling, and there is a decrease of GLUT4 levels, meaning there is a more insulin-resistant conditions, and this leads to oxidant stress and endothelial cell damage. Altogether, these contributed to the atherogenic effects of the epicardial fat surrounding the coronary arteries. Clinically, we and others found that the higher is the epicardial fat volume, the more incident is the coronary artery disease. This has been clearly demonstrated by several clinical trials, so that there is an independent role of the correlation between epicardial fat volume or thickness in predicting coronary artery disease. And you may argue this is driven by obesity, but actually it's not. So we found that the correlation between epicardial fat and CAD is partially independent of obesity. Just to give you a visual example, on your left, you have patients with the CAD being non-obese with a very large epicardial tissue, as you can see the free space on the top of the right, the free ventricle. Whereas on your right, you have an obese patient without CAD, and you can see that actually the epicardial fat is much smaller as compared to the CAD non-obese patient. Then there is another big area, developing area. We have 2 NIH grants on these, and about the arrhythmogenic effects of epicardial tissue, because again, epicardial fat surrounding the left atrium has specific arrhythmogenic effects, and inflammation, as you can see on the left, is still playing an important role, but there is something peculiar about the left atrial epicardial fat, and particularly about the release of fibrotic factors through this vesicle. You can see the ECM are particles, are vesicles that are in direct contiguity with the atrial myocardium, and they release through the epicardial fat and into the atrial myocardium pro-fibrotic factors, causing reentrant circuits. But not only, what is very interesting that the excessive FFAs release of from the epicardial fat goes directly in the atrial myocardium, affecting the cardiomyocyte continuity. So there is a sort of, it's called zigzag effects. So there the atrial myocardium fibers are no longer in continuous. They have these interruptions, and this seems to be associated with the prolonged action potential duration and again reentrant circuits. And then there is the role of increased autonomic output, because the epicardial fat is highly enriched with the ganglionate plexi that can increase the sympathetic tone and altogether contribute to the to increase the risk of arrhythmias, particularly atrial fibrillation. And as I mentioned before, the epicardial tissues has a different transcriptome, and depending where it's located. And this study nicely show, and we have an ongoing study that confirm, actually have a new and additional findings that will be published soon, showing that the transcriptome between periatrial, periventricular, pericoronary epicardial fat, so different epicardial fat locations, is very different. So, and this has a role in having a pro-inflammatory effect for coronary arteries, or pro-arrhythmogenic effects for the periatrial fat inducing atrial fibrillation. Clinically, there are several studies showing that epicardial fat is higher in patients with atrial fibrillation, and tends to be higher in those with persistent as compared to those paroxysmal atrial fibrillation. And either if you measure as a volume or as a thickness, so there is clearly a higher epicardial adipose tissue in patients with persistent chronic AFib. We have for this, again, we have an ongoing study, one of the NIH grant, it's about the looking at a transomic analysis of epicardial fat in atrial fibrillation. We are analyzing all the, sorry. So we're analyzing the epicardial tissue from a different aspect, and we are looking at the transcriptome. We are looking at the on the metabolomics, proteomics, and also the clinical components. Then there is a newer exciting area, which is the role of the epicardial tissue in heart failure. And this is very developing and still controversial. We have another NIH grant that has been submitted, that is under review, looking at the role of the epicardial tissue in heart failure with the reduced ejection fraction and with preserved ejection fraction. So the role of epicardial tissue in heart failure has some peculiar characteristics, where the sympathetic tones of the increased catecholamine and noradrenaline secretions seems to have an important role in affecting both systolic and diastolic function. But also very important, the increased FFA influx into the myocardium seems to play an important role in inducing apoptosis, particularly in heart failure with the reduced ejection fraction and a cardiomyocyte disarray leading to systolic dysfunctions. Fibrosis and inflammation are also important components affecting both diastolic and systolic function in heart failure. As I say, the role of the epicardial adipose tissue in heart failure is still under investigation because there are some conflicting results. Some studies have found increase, other decrease epicardial adipose tissue mass, and it seems to be quite established that in FFF, so with preserved ejection fraction, the epicardial tissue seems to be higher than control, whereas in heart failure with reduced ejection fraction, there is a decrease epicardial tissue. But again, we have ongoing investigations, and other groups are also looking at the role of epicardial tissue in heart failure. So, as I mentioned before, epicardial tissue, it's definitely it's a factor, it's a risk factor, and as every risk factor needs to be measurable to be a good and reliable risk factor. So even I'm a very atypical endocrinologist. I'm not a cardiologist, but most of my training and the expertise is also in cardiology. So I developed these technique using the standard transthoracic ecocardiogram to measure the thickness of the epicardial fat. You can see is part of the long axis parasternal view that you can appreciate the epicardial fat thickness, particularly in end systole, when both the right and left ventricle walls collapse. You can measure the widest thickness of the epicardial fat, and you want to be the most perpendicular possible to the right and left ventricle to have a good measurement. Of course, it's ultrasound, so it has some limitations. It's operator limitations, but it's very, of course, it's cheap, readily available, and many studies have shown a good coefficient of correlation, and is reproducible technique. And what is interesting that the epicardial fat thickness measured with echo, it's a marker of visceral fat, because we compare the epicardial fat measured with echo with the CT and MRI measuring intra-abdominal fat, and we found a very strong correlation. So in order to have a measure of visceral fat in your patients, you may not need a CT and MRI. You may do just an ultrasound, and you have a very good and reliable marker of visceral fat. Even more interesting, we look at whether the epicardial fat and the intramyocardial fat may be related, because it's not just important the visceral fat, but it's even more important, the intracellular fat content. And we look at the correlation between the epicardial fat measured with echo and the intratriglycerides content measured with the MRI spectroscopy. And we found something extremely fascinating, that there is a very strong and independent correlation between the epicardial and the intramyocardial fat. And that may be very interesting in setting of the heart failure, where the intramyocardial fat content seems to play an important role. Then let's move to therapeutics. So this is, of course, it's a big topic, and again, in order to be a good risk factors, needs to be measurable, and we show that it's measurable, but also it needs to change with and be tracked with interventions. And we particularly focus on the effect of the GLP-1 receptor agonists and SGLT2 inhibitors on the epicardial tissue. And we found some different effect of these GLP-1 SGLT2 inhibitors depending on the locations. So GLP-1 targeting left atrium may mostly reduce inflammation and increase FA-phase oxidation. When it targets the coronary epicardial tissue, GLP-1 agonist may also induce a pre-adipocyte differentiation and adipocyte browning. This is huge. It's a very important findings, because when you use this medication, you may target the epicardial fat, and I'll show you later more details. With SGLT2 inhibitors, they may have a different effects, and interesting, they can induce sympatholysis. So they induce also lipolysis and ketogenesis. So the epicardial tissue is highly rich in ketones and in FA-phase. So SGLT2 inhibitors seems to target epicardial fat and enhance FA-phase oxidations and lipolysis, inducing more available FA-phase for the myocardium that is going to use these substrate instead of glucose, that is going to actually release into the urine with SGLT2 inhibitors. So this is very interesting. I'm going to give you some details. So the cardiovascular beneficial effects of GLP-1 are now established. I was in the advisory board of the liraglutide with Victoza many years ago, and that was the first GLP-1 with the leader study showing the cardiovascular beneficial effects. Then now you have, of course, the semaglutide, which is the weekly injectables that have shown a clear, strong beneficial effect in heart failure, both with reduce and preserve ejection fraction. Of course, you have daily GLP-1 and weekly GLP-1. We use much more for the weekly GLP-1 than the daily for convenience, but also for more important cardiovascular benefits. So we look at whether the GLP-1 could have any effect on the epicardial fat, and one of the first studies was to look at the liraglutide effects on the epicardial fat. So we did this randomized clinical trial where we randomized patients either on liraglutide or metformin, patients with diabetes, well-controlled diabetes. The A1C inclusion criteria was an A1C lower than 7. And we found that an amazing result, that those randomized to liraglutide had a huge reduction of the epicardial fat, about 3 and 6 months. You can see almost 30% or even higher than 30% of the epicardial fat thickness reduction on the GLP-1 liraglutide, as compared to no changes on those who were continued on metformin and placebo. And then we will look at the effect of the weekly GLP-1, both semaglutide and dulaglutide, on epicardial fat. And we found that both sema and dulaglutide induce a significant reduction in the epicardial tissue. And there was a slightly superiority of semaglutide versus dulaglutide on epicardial fat reductions. This study did not include the higher dose of the now available for semaglutide, so the 2 milligrams or the 2.4 and the 3 and the 4.5 milligrams of the dulaglutide. So we now looking at whether we have another study that in preliminary results were presented at the American Heart Association and Heart Treatment Society, and it's called LEAD study, where we are looking at the effect of liraglutides of daily GLP-1 on atrial fibrillation, because we believe that the epicardial tissue is a new substrate for atrial fibrillation, because we know that GLP-1 can target the epicardial fat and reduce it. We want to look at whether the treatment with GLP-1 can be a novel approach to treat patients with atrial fibrillation. So results of the study will be published soon, so we can update you soon. I can give you just preliminary results that patients randomized to liraglutide and the risk factor modifications had a more significant left atrial epicardial fat changes as compared to those randomized only on risk factor modifications. But more interesting results on atrial fibrillation recurrency in these patients will come, and we had evidence that those treated with liraglutide had a lower rate of atrial fibrillation recurrency as compared to those who treated only with the risk factor modifications. Again, this is another details looking at the different atrial fibrillation status and those at baseline and 6 months post ablation within the LEAD study, and we found profound differences in patients after 6 months after ablation in terms of reduction of both persistent and paroxysmal atrial fibrillations. And these were still considering both groups, liraglutide and risk factor modifications group. So we definitely saw a significant changes in the recurrence of the atrial fibrillation after ablation, 6 months after ablation in those who were treated with liraglutide. Why and how GLP-1 can work on epicardial fat and induce this improvement in atrial fibrillation and other cardiovascular outcomes. So we were the first group to discover that the human epicardial tissue actually express the GLP-1 receptor. You can see with this immunofluorescence panel that on your left, you have epicardial tissue GLP-1 receptor on the top row, and which is highly present in both diabetic and non-diabetic epicardial fat, where it was basically absent in a subcutaneous adipose tissue, neither in diabetic and non-diabetic patient. So basically, these studies show for the first time that the epicardial tissue express the GLP-1 receptor, not just the gene, but also the protein. And this, of course, opens the hypothesis, the strong hypothesis that there is a direct effect of the GLP-1 receptor agonist on the epicardial fat mediated by the GLP-1 receptors. Even more interestingly, we look at whether the activation of the epicardial adipose tissue GLP-1 receptors was associated with some metabolic changes. And we found that when you stimulate the GLP-1 receptors within the epicardial fat with these GLP-1 analogs, you actually induce higher FFase oxidations, meaning that you make the free fatty acids an available source of energy for the myocardium. Instead of being a detrimental effect, you improve the oxidation of FAs through the GLP-1 activation of the epicardial fat GLP-1 receptors. So they are better utilized by the underlying myocardium. So they become a fuel for the myocardium. Then we have another molecule extremely interesting that we are now usually we use routinely in my patients. I use the tirzepatide, which is actually dual agonist. It's not just a GLP-1 receptor agonist, but a GLP-1 GIP, which is glucagon insulinotropic peptide, which is another gastrointestinal hormone, And this hepatitis has a dual agonistic effect and has a strong weight loss reduction. We're talking about almost 25% of reduction with a higher dose. So far is the most effective the weight loss medications we have. So, and then it's triagonists, so triple agonists are coming, and they also have a glucagon receptors. So they were GLP-1, GIP, and glucagon receptors agonists, and they seem to be even more weight loss effective than tirzepatide, so the dual agonist. Why is this so important for epicardial fat? Because in another study, more recently, we found that the epicardial fat express both GIP and glucagon receptors. So those were stimulated by tirzepatide and the triple agonist. So you can see clearly that the epicardial fat express with the red arrow the receptors and the proteins for the GIP and the glucagon receptors, and these seems to be mainly located in the crown-like structures, which is very interesting because they are apoptotic cells. They reflect apoptotic changes within the adipose tissue. So these receptors are located mostly in these epicardial fat cells. And we look at whether the expression of these receptors, all of the three, GLP-1, GIP, and glucagons, could be related to the volume of the epicardial fat. Yes, as we found that the bigger is the epicardial fat, the more the higher is the expression of these receptors for all of the three. So you have a correlation between the epicardial fat volume or thickness and the receptors of the GIP, GLP-1, and glucagon receptors. When you stimulate the GIP, which again are receptors stimulated by tirzepatide, you also improve free fatty acid metabolism. Similar to GLP-1, there is an improved oxidation of phase. They are more available for the underlying myocardium. Interestingly, when you stimulate the glucagon receptors, and they will be within this new triple agonist, you improve adipogenesis. You may argue with me that it's not good to induce adipogenesis. It's actually the opposite that you may think, because when you improve adipogenesis, you improve the fat cells sensitivity, insulin sensitivity. So the cells become more insulin sensitive and more prone to receive the beneficial effects of the medication. Then we have SGLT2 inhibitors, another huge group of medication with strong cardiovascular protection. You all know, I'm sure, the beneficial effect of DAPA in heart failure. And we look, of course, at the effect of dapagliflozin on the epicardial fat. And we compare with the similar study design. It was a randomized clinical trial. The patients were randomized either on DAPA plus metformin or metformin placebo. And we found that those on dapagliflozin had a significant reduction in the epicardial fat, whereas the reduction in those randomized to metformin only was not clinical and statistically significant. And these results were confirmed by other studies looking at the other SGLT2 inhibitors, particularly empagliflozin, canagliflozin, and all of these studies show a significant reduction in epicardial fat on the SGLT2 inhibitors. What's the potential mechanism that could be of interesting? As I mentioned at the beginning, so SGLT2 inhibitors may have these lipolytic effects on epicardial tissue, so increase the availability of FAs and make these FAs available as a fuel for the myocardium. However, as I mentioned before, they increase ketogenesis, so they increase ketones induced by SGLT2 inhibitors, and may also be an interesting alternative fuel for the myocardium, where you don't use glucose, which is highly expensive for the myocardium, but use ketones. And ketones are cheaper in terms of energy consumption, and the myocardium use an effective but cheaper and less expensive fuel. The SGLT2 inhibitors may improve and reduce epicardial fat also through increasing GLUT4 expression. And these GLUT4 is the glucose transporter, so will help to better transport glucose into the cells and improve the insulin sensitivity. This seems to be another potential mechanism. So with all of these lecture, I wanted to give you a summary of about 20 years of research, and I give you some evidence that the epicardial adipose tissue is now considered a new cardiovascular risk factor and a therapeutic target. Thank you very much for your attention.
Thank you very much, Dr. Iacobellis, for the amazing lecture, and congratulations in all the work you've done on epicardial adipose tissue and bringing us as a new risk factor. So for the code, you will see there on the chat, so you get the credit for the lecture for everyone, and please put your questions in the Q&A, so we'll start going through them. I'll start with one question that we were briefly discussing before. You mentioned in your reviews as well of this, and you mentioned it in the lecture, that if you want to stop sharing the screen, maybe, so we can. Perfect. So
yes,
the changes over time, and you mentioned that the role in the neonates may be different, and the role at the end of life or the sicker patients may be different of EAT volume. How could you explain a little bit more about that and the difference at the different stages?
Yes. This is a very interesting because makes a point on the physiological function of the epicardial adipose tissue. So it's not just a pathological and detrimental fat depot. When we are born, so we have a lot of epicardial fat, and this epicardial adipose tissue has brown fat-like features. So brown fat, it's a kind of adipose tissue that we unfortunately lose with aging, but in the very early stage of our life. And the brown fat would be ideally the best adipose tissue we could have, because it's a thermogenic fat depot, produce energy and heat to the heart. To give you an example, in comparative anatomy, the polar bears, which hibernate, when they have a huge amount of epicardial fat with brown fat characteristics, that allow them to hibernate for months to receive energy and heat from the fat tissue. Unfortunately, or fortunately, we are not polar bears, but we don't have these features. And when we get older and when we get sicker, and particularly more obese with more visceral fat, the brown fat like characteristics seems to decline completely, and the fat becomes more pro-fibrotic, more pro-inflammatory, and with apoptotic changes, which lead, as we were discussing before, to some paradoxical changes with epicardial fat. You can actually see a lower epicardial fat volume and cells because these apoptotic and fibrotic changes. What is amazing to me that we are seeing some preliminary results of the GLP-1 particularly. It seems to how can I say, refresh some of the brown fat like characteristic of the epicardial fat, and that going like a rejuvenation of the epicardial fat that may be beneficial for the heart.
Thank you very much. Yeah, I think it's a lot more complex than just volume at different stages, but that was very good. Thank you. So we have a question from Rob Ostfeld, our Director of Preventive Cardiology. He says, thank you for your great talk. 2 questions. Why do some people develop this high-risk EAT phenotype and others not? And the second question is, can lifestyle changes such as exercise or more healthful dietary pattern modify EAT?
All right, so 2 great questions. So the first, we don't know yet why. Of course, we know that there are some ethnic differences. We did some studies looking at the different ethnic groups in epicardial fat, and we found that South Asians and Hispanics tend to have a higher epicardial fat as compared to Caucasians and Afro-American. That could be one factor. As I show you, there are genetic differences, so definitely there is a potential genetic predisposition. Definitely patients with more visceral fat distribution tend to have much more epicardial fat than those with peripheral fat distribution. So, to the second question, yes, there were studies looking at the lifestyle modifications like diet and exercise and also bariatric surgery. So exercise, unfortunately, seems to be not as effective as medications or diet in reducing epicardial fat. However, there is some studies, not mine, but they show that there is some interesting changes in the interleukin 6 signaling after exercise within the epicardial fat. So there is an increase in the interleukin 6 levels after exercise within the epicardial fat, meaning that the exercise may induce some positive changes. Maybe you don't see a reduction in the volume and the thickness, but you may see qualitative changes. Diet, very low calorie diet, we published that, definitely significantly decrease the epicardial adipose tissue. Bariatric surgery, there are some conflicting results. Some studies show a significant reduction, other studies show no reduction.
Thank you very much. We have a question from Nicola Tarantino, one of our EP attendings. He asked about the gender, also sex differences in atrial EAT volume. He's an electrophysiologist, so I think he's thinking about the relationship of this with AFib.
Yeah, another very nice question. Thank you. We see not huge difference, but statistically significant difference between women and men. And but it's more driven by the fat distribution, because women tend to have a more peripheral than visceral fat. So the difference, in my opinion, there is a difference, but it's because of the different fat distribution. So if you have a woman with more visceral fat, will have the same epicardial tissue as a man, because it is the fat distribution that plays the role. However, to complete my to further address, we are seeing that postmenopausal women tend to have a higher epicardial adipose tissue independently of BMI and waist circumference. So definitely there is much more, and I have some data that a fellow of mine is analyzing, looking at we see, I don't want to say because I didn't see the final results yet, the final statistics, but we saw some preliminary correlation between gonadotropins and epicardial adipose tissue. That means there could be a role in sexual hormones also in regulating epicardial fat. And so probably there is much more than visceral fat distribution.
Very, very interesting. Thank you very much. A question from our fellows. So they talk about, you mentioned about the effects of the GLP-1 receptor agonist decreasing epicardial adipose tissue volume. Right now, we decide who we start this GLP-1 agonist. Well, initially because of diabetes, now we're seeing, effects even in those that are overweight, right? Do you think in the future we may be using the visualization of epicardial adipose tissue to decide which patients would benefit from GLP-1 agonists? How far are we from this?
Yeah, that would be definitely my goal. You're perfectly right. I agree with you. We published recently a study showing that the ambulatory epicardial fat measurement is associated with some predictivity of the cardiovascular risk in diabetic and obese patients. So I think that there's not, of course, a routine measurement, but there are growing evidence showing that again, an ambulatory on-site echo with, I'm using portable echo. So you can use this small device for you need 5-10 minutes, and you can definitely have a good prediction of and as you said, you can customize. This is would be very would be a precision medicine, and not at the future, I think of the present, because as you said, if we identify those with a high risk, those would be a better responders to GLP-1. We can measure the epicardial fat and we see, oh, this patient would be a better responder to SGLT2 or GLP-1 based on the epicardial fat measure. This is what I'm doing in my practice. You know, we are facing, of course, the fact that the epicardial fat measurement doesn't have a diagnostic code, so it's not, you know, being practical in our clinical practices. So it's now reimbursable, the measurement. I try in the past to code to bill under ultrasound of soft tissue because it's a soft tissue. There were some bounce from the insurance. So, but I think that would be definitely my next step.
No, that's great. I think that's why a lot more research is needed in the field, just to showing the beneficial effects of measurement on top of things like calcium score or plaque and clinical risk factors. So I agree with you. So a question from Daniel Lorenzati that is doing work in particular in this field. He says, congrats for the talk and the Nature review that we liked a lot. Are there any sex, age, and BMI adjusted nomograms for EAT volume? So the question I think is great. And how do we individualize the results for a certain group of patients and to trigger the management?
Yes, so most of these results were sex and BMI adjusted. So I don't think BMI plays a major role. So I don't think you need to focus on BMI. So it's the body fat distribution, and that definitely will be the factor, the parameter you want to follow to stratify the risk of your patients. And again, as we were discussing, the customization of the treatment. It's definitely happening already, and we may do even much more by using this simple and non-invasive tool to better tailor our treatment.
Yeah, I guess it's difficult sometimes when you look at different groups, right, of people. If you look at different cohorts and the median value is different. So I've seen some papers labeling as high risk over the median, some using 100. So I think some normalization of what is high risk.
Definitely, we did publish in the past some high like threshold value of the epicardial fat thickness measured with echo, and I think that they are reliable. Other studies reproduce. So talking about the thickness, so if you have an epicardial fat thickness in men higher than 8 millimeters, definitely you have patients a higher cardiovascular risk and higher than 7 in women. So these were published and again replicated. Of course, we may need, I agree with you, a more standardized and uniform value for AT volume. For example, we don't have that yet, and but we can work on that.
Great. Well, thank you very much for the lecture. This was wonderful, and we'll stay in touch for sure for collaboration.
Oh, absolutely. So thank you very much for inviting me. It was a great pleasure, and yes, I look forward to work with all of you. Thank you.